Cancer. We are live.
Hello, good evening, everyone. It's a pleasure to welcome you and invite you for a recent clinical updates on common cancer. Yesterday was a brilliant day, excellent discussion by all the faculties. And today is the day two where we are focusing on breast cancer and GI cancer. Once again, good evening, and it's a pleasure to welcome our convener, Dr. Devesh Goel. He's a senior consultant medical oncologist at the prestigious Fortis Hospital, Jaipur. And we carry the greetings from the Pink City, Jaipur. So once again, a very good evening and warm welcome to all of you for this webinar. And over to Dr. Devesh Goel for his opening remarks and setting your contacts for today's discussion. Over to you, Dr. Devesh.
Thank you, Tarun. Thanks to all faculties. So today is the day two of the webinar is the recent clinical update on common cancer. Yesterday, we discussed about this breast cancer as well as the lung cancer, various aspects, immunotherapy, targeted treatment, as well as newer updates in this breast as well as the lung cancer. So today, we will discuss on this GU as well as GI cancer. So without wasting the time, I invite for the first topic to Dr. Ankit Agrawal, who is Senior Medical Oncologist at Gitanjali Medical Hospital and College, Udaipur. And he will deliver the talk on this abstract on this prostate cancer. So over to you, Dr. Ankit.
Thank you, sir. Thanks a lot again. Glad to be part of this webinar. Thanks a lot to all the organizers and especially Devesh Goel. So can anyone share my slides, please?
Yeah. So can we have the slides now, Nishant?
Yes, sir.
Can you make it slideshow, please? Yeah, great.
Yeah. Okay.
Yeah, Dr. Ankit, sir, the slides is with you. You can just have to say next slide, and my colleagues will help you out. Over to you, sir.
Sure. Thank you, Tarun bhai. Thanks a lot. Okay, so without wasting further time, we are going to start our discussion. So the next discussion, what we're going to discuss in the next 5 to 7 minutes is a phase 3 trial that has been very interesting. I just got to I just read about this recently, and I'm glad that I could present this in front of you. So this was a recent ASCO annual ASCO meeting. It was presented. It is a phase 3 study, the TELAPRO-2 study. What it showed was the combination of talazoparib with enzalutamide versus enzalutamide plus placebo. What was the result of when we gave talazoparib plus enzalutamide when it was compared with enzalutamide alone in the first line treatment of metastatic prostate cancer harboring homologous recombinant repair gene alterations? Next slide, please. So what was the background of combining PARP inhibitor with an androgen receptor inhibitor? So we all know that PARP inhibitors, what it does, it basically disrupts the single strand breakage, and it leads to basically the repair of the single strand breakage is disrupted, and thus the inhibitory activity of these agents leads to cancer cell killing. Androgen receptor inhibitors also, we know androgen receptors are very important for growth of the prostate cancer cells. So when androgen receptors are inhibited, it basically has the tendency to upregulate the PARP activity, and also it downregulates the HRR gene expression. Combination of these two have a synthetic ability to kill the cancer cells, and in both in those who have HRR gene alterations or in those without any HRR gene alterations. Basically, suppression of the AR activity as well as disruption of the single strand breakage repair, it leads to a synergistic activity and leads to enhanced killing of the cancer cells. We all know enzalutamide is the current standard of treatment in the first line setting in metastatic CRPC. So TELAPRO-1, basically what it did was a talazoparib monotherapy at a dose of 1 milligram per day had shown a durable anti-tumor response and a manageable safety profile in those patients who were heavily pretreated, who were diagnosed at metastatic CRPC and who had HRR gene alterations. So this is the phase 3 trial that had evaluated a dose of 0.5 milligram per day of talazoparib with a combination of enzalutamide and it was compared to enzalutamide alone with a placebo in first line setting of metastatic CRPC. Second slide, please. So this was the trial design. First line metastatic CRPC patients of ECOG performance status of 0, 1 who already had ongoing androgen deprivation therapy were included in this. Prior abiraterone or docetaxel also, the patient had received abiraterone or docetaxel in the castrate sensitive setting were included. HRR gene alterations, all comers cohort only, either deficient or non-deficient or unknown, these are also included in the trial. The first arm was talazoparib with enzalutamide. Talazoparib given at a 0.5 milligram dose. Enzalutamide was 160 milligrams once a day, the usual normal dose that we use routinely. And it was compared with placebo versus with enzalutamide 160 milligram once daily. The primary endpoint was radiographic progression-free survival. Secondary endpoints were overall survival. And the other secondary endpoints were time to cytotoxic chemotherapy, progression-free survival by investigator assessment, objective response rate, patient-reported outcomes, and safety profile. Next slide. Next slide, please. Yes. So what were the study cohorts and enrollment? So the cohort included even those patients who did not have an HRR gene alteration. They were also included in the trial. So non-deficient or unknown, the number of these patients was 636. And those patients who had a homologous recombinant repair mutated gene, they were around 399. They were also randomized separately, and the patients who had an unknown status of HRR were randomized separately between the two arms. Next slide, please. So TALAPRO-2 HRR deficient patients, the baseline demographics and disease characteristics were well balanced between the two arms. Patients who had received prior abiraterone or docetaxel, they were around 37% of the cases had already received some form of treatment in their castration sensitive setting. The average PSA that was seen was around 19 to 20, in between 18 to 20. Next slide. So this was the baseline HRR gene alterations characteristics. The most common mutation that was seen was the BRCA2, 31% and 36.7%, 31% in the talazoparib plus enzalutamide arm, and ATM, the CDK12, CHEK2, BRCA1, MLH. These were also genes that were seen, and these were patients were included in the trial. Next slide. So this was the radiographic progression-free survival Kaplan-Meier graph, and as you can see, the graph, both the graphs have started separating as early as 2 months. The talazoparib with enzalutamide arm had shown a significant improvement in the radiographic progression-free survival as compared to those patients who received only enzalutamide. The median PFS was 13.8 months in enzalutamide arm, and it was not reached in talazoparib with enzalutamide arm. A p-value very significant, hazard ratio 0.45, showing a 55% reduction in the risk of progression. Next slide. This is the forest plot. Very interestingly, this showed that almost all the subgroups had a good amount of benefit with addition of talazoparib. Special mention about those patients who had a BRCA1 or 2 mutated gene. These patients were the best to benefit. As you can see, those patients who had a BRCA1 or a BRCA2 mutation, their hazard ratio was 0.2, showing an 80% reduction in the risk of progression. Next slide. Similarly, selected gene subgroups, if I talk about the most commonly, the patients who were benefited the most were BRCA mutated patients. 0.17 and 0.19 were the hazard ratios. And overall, if I talk about, the hazard ratio was 0.44. CHEK2 mutated patients were the patients who had marginal benefit. Other gene clusters, 1.5 was the hazard ratio, showing that enzalutamide was better as compared to the combination. Otherwise, the most common mutation that we had seen was the BRCA mutations, and they were the best to benefit with the addition of talazoparib. Next slide. Overall survival, there was an interim analysis of overall survival in those patients who had HRR deficient genes, and it showed that the median OS in those patients who had received enzalutamide was 33.7 months, and it had not reached in the combination arm. Hazard ratio 0.69, p-value was not significant, but the data is immature. Probably in the next few years, we'll get to know about the data of overall survival, and we just hope that we get a good overall survival benefit with the addition of talazoparib. Next slide. Time to PSA progression in those patients who were HRR deficient was significantly better in the combination arm. Median time to progression, PSA progression was 28.6 months in the combination arm as well as compared to 11 months, which was quite significant. Hazard ratio 0.41, a 59% reduction in the risk of PSA progression. Next slide. Time to cytotoxic chemotherapy also was quite significant in those patients who received the combination arm. The median time to cytotoxic chemotherapy, the median time was not reached in both the arms, but the p-value was quite significant, 54% reduction in the risk of 54% reduction in the time to cytotoxic chemotherapy receiving. Next slide. Overall response rate, as you can see, 67% of the patients had either a partial response or a complete response. If I talk about stable disease, if we add up, at least more than 85% of the patients had a response to the combination arm. And the CR rate and PR rate combined was 40% in the arm who had received enzalutamide alone. Next slide. So this was the summary of the treatment-related adverse effects. There were no cases of myelodysplastic syndrome or acute myeloid leukemia. This was previously in the phase 2 trial. There were a few patients who had been associated with myelodysplastic syndrome, but in the phase 3 trial, there were no cases who had suffered from MDS or acute myeloid leukemia after receiving talazoparib. Pulmonary embolism was reported in 2% of the cases, and in the combination arm, and 1% in those patients who had received enzalutamide. Next slide. So the side effects that has to be mentioned, talazoparib and enzalutamide combination arm, the patients had suffered more of hematological toxicities like anemia, neutropenia, thrombocytopenia. Anemia was seen in 42%, neutropenia 15%, and thrombocytopenia in 5.6%. Grade 3-4 anemia, median time to onset was 3 months. It was reported in 40% of the patients who had received the combination arm. Next slide. Patient reported global health status. Talazoparib, the combination arm, significantly prolonged time to definitive clinically meaningful deterioration in the global health status or quality of life. And the median was 27 months versus 19.3 months. Hazard ratio 0.69. Next slide. So these are the conclusions. In this large randomized trial, the patients who had been treated, the patients who were included were first-line metastatic CRPC with HRR gene alterations. Combination of talazoparib with enzalutamide resulted in a statistically significant and clinically meaningful improvement in the primary endpoint, radiographic progression-free survival, over placebo plus enzalutamide. And the response was the best seen in those patients who had BRCA mutated gene versus those patients who were not BRCA mutated. Although OS data are immature, there is a favorable trend towards improved survival for patients with HRR gene alterations. No new safety signals were identified. On-target anemia was the most common grade 3-4 adverse effects. And time to definitive clinically meaningful deterioration in global health status was significantly longer in talazoparib plus enzalutamide arm versus enzalutamide. I think I'll conclude here. If there are any questions, I would be happy to answer.
Okay. So just my query, are you using frequently the HRR panel in the CA prostate cancer patients? Clinical?
So actually, the thing is, I have been using HRR gene alteration. I've been using the panel, but the issue with this is if the patient turns out to be positive, first of all, it's difficult to counsel them to take PARP inhibitors. Second, if the patient starts PARP inhibitors, my experience with PARP inhibitors in prostate has not been very good. There have been a lot of side effects. I don't know, somehow olaparib has not done well in my patients who have BRCA mutated CA prostate. So it's scary for me to use a PARP inhibitor in CA prostate. I don't know somehow what has happened.
I think the little bit I have seen the much side PARP inhibitors.
Okay.
I think the anemia, thrombocytopenia, leukopenia are more.
Yes,
I
yes,
think with
and
reduced dose slightly is manageable.
yes, yes, yes.
Yeah,
Reduced dose and full dose is I don't think probably Indian patients don't tolerate that.
yeah. Okay. Thank you, Dr. Ankit. So for the next talk, I will invite Dr. Rohit Swami, and he is consultant medical oncologist at Narayana Multi-Speciality Hospital, Jaipur, and he will discuss on this abstract on the randomized phase 3 trial on muscle invasive bladder cancer. So over to you, Dr. Rohit. I think time is very limited. So
Yeah.
conclude in.
Good evening, everyone, and thank you, Devesh Boss, for giving me this opportunity to talk in this academic fiesta, as well as giving such a nice introduction. So I'll be presenting 5-year survival data of this Vesper study, which was a multicentric randomized phase 3 study, which compared dose-dense MVEC versus gemcitabine cisplatin in perioperative setting in both neoadjuvant as well as adjuvant setting, though much more patients are in neoadjuvant setting. Next slide, please. Next, please. So at present in 2023, we know that giving perioperative chemotherapy in muscle invasive bladder carcinoma is a standard of care. We have level 1 evidence that neoadjuvant chemotherapy in the form of cisplatin containing regimen give a survival benefit of at least 5%. And we have low evidence for adjuvant chemotherapy, but still, if there is a muscle invasive bladder cancer, we always go for adjuvant chemotherapy. Next slide, please. And till date, till the 5-year overall survival of this study was published, there was no optimal perioperative chemotherapy for muscle invasive bladder cancer. We were commonly using two regimens. Either we were using gemcitabine cisplatin or we were using dose-dense MVAC. And there were variable complete pathological response of 10 to 50% in different phase 2 study. And Vesper trial is the only randomized phase 3 study which compared dose-dense MVEC with gemcitabine plus cisplatin in perioperative setting. Next slide, please. And the trial design, there were two arms, 4 cycles of standard doses of gemcitabine and cisplatin as perioperative chemotherapy, either in the neoadjuvant setting or in the adjuvant setting, and 6 cycles of dose-dense MVEC, whether in the neoadjuvant or adjuvant setting. Next slide, please. Inclusion criteria of this study was pure or mixed urothelial bladder cancer, muscle invasive bladder cancer, pure adenocarcinomas or squamous cell carcinoma or neuroendocrine carcinomas were excluded. PS of all the patients were 1 or 0. The patient who received neoadjuvant chemotherapy were those who were having T stage of more than T2 with no lymph nodes. So this was however, not a common scenario, but in this study, for the neoadjuvant setting, N0 patients were selected, and the adjuvant chemotherapy was given in the patient who had T3, T4, or a node positive. Next slide, please. So 500 patients were randomized at 28 centers from 2013 to 2018. 7 patients were excluded from the interim analysis because of exclusion criteria, and around 56 received adjuvant and 437, that is 88% of population in this study received neoadjuvant chemotherapy. Primary endpoint was PFS at 3 years, and secondary endpoint and final analysis was overall and disease-specific survival at 5 years. Next slide, please. And if we see the toxicity data here, so we can see that 60% of patients were able to receive all the 6 cycles of dose-dense MVEC, and around 66% were able to receive all doses of gemcitabine and cisplatin in neoadjuvant setting. Similarly, in the adjuvant setting also, it was around 37% compared to 46%. So around 60% of patients in neoadjuvant setting received dose-dense MVEC, and radical cystectomy was performed in more than 90% of cases. Most common side effects were with dose-dense MVEC, and these were asthenia, anemia, GI side effects, loose motions. But this study showed us that this dose dense MVEC is feasible at our clinics. Next slide, please. And coming to PFS benefit at 3 years, so intent to treat population, there was PFS benefit, but it was not reaching to statistically significant. But in the population which received neoadjuvant chemotherapy, there was statistically significant PFS benefit at 3 years. It was around 66 in dose dense MVEC as compared to gemcitabine and cisplatin. Next slide, please. And coming to 5-year overall survival, then again intent to treat population, there was no significant difference in overall survival in dosed as MVEC as compared to gemcitabine cisplatin, though there was a trend of improved survival. But in the neoadjuvant chemotherapy group, which was consisting of 88% of population, there was significant survival benefit in the patient who were receiving dosed as MVEC in the neoadjuvant setting as compared to gemcitabine and cisplatin in neoadjuvant setting. Next slide, please. And disease-specific survival, there was significant survival benefit, disease-specific survival benefit in intent to treat population, that is all patients, as well as in the neoadjuvant group. Next slide, please. And coming to the causes of the death, so there was 94 patients in the gemcitabine cisplatin died because of disease progression as compared to 63. So there was less progression in those days, MVEC-M. And other deaths were quite matchable in both the arms. Next slide, please. And ongoing overall survival multivariate analysis. So there was significant interaction between the treatment arm, that is the chemotherapy we chose, as well as chemotherapy timing. And hazard ratio of dose as MVEC and gemcitabine and cisplatin were calculated according to the neoadjuvant adjuvant chemotherapy. For neoadjuvant chemotherapy, hazard ratio was 0.7, and for adjuvant chemotherapy, it was 1.9. Next slide, please. And if we see the cumulative dose of cisplatin received by the patient, so the patient who received less than 4 full doses of cisplatin had poor overall survival in both the arms, as compared to those patients who received 4 or more than 4 full doses of cisplatin in both the arms. So response is totally dependent on the dose of cisplatin the patient has received in neoadjuvant or adjuvant setting. Next slide, please. So coming to discussion of this study, so perioperative setting versus neoadjuvant chemotherapy. So Western phase 3 trial was designed 10 years ago in 2013. Still at that time, there was good practice of giving perioperative chemotherapy. And first lesson of Vesper gives us that majority of the patient also in this study, 90% around, received neoadjuvant chemotherapy. And this was better implementation of neoadjuvant chemotherapy according to the guidelines, which at present also we follow, that we have to give neoadjuvant chemotherapy in muscle invasive bladder cancer as compared to adjuvant treatment. And adjuvant treatment group analysis in this study was not conclusive because only 56 patients were there on adjuvant arm. Next slide, please. So concluding my talk, Vesper trial is a milestone in history of chemotherapy for muscle invasive bladder cancer. This is a treatment changing study. Dose dense MVEC provided a better overall survival at 5 years and also significantly improved disease specific survival as compared to gemcitabine and cisplatin in perioperative setting. And final analysis also confirms that dose dense MVEC is superior to gemcitabine and cisplatin and is feasible in our clinic. So Vesper final analysis is practice changing and should impact future clinical cancer research. Thank you.
Thank you, Rohit. So just my query from, so do you routinely use in clinical practice dose dense MVEC? I think I have still not used
gemcitabine and cisplatin, but I will now onwards, I will definitely try because there is survival benefit and we can't deny a patient survival benefit if dose dense MVEC is giving survival benefit as compared to gemcitabine and cisplatin.
Okay.
So fit patient, definitely fit patient I will first try, and if it is tolerable and there are no much side effect, then I will change gradually toward this regimen.
I think over a time, the cisplatin and gemcitabine shows good response, as I have seen the following this.
Yeah, but comparison for the comparison, this is the only phase 3 study which is clearly compared between gemcitabine cisplatin as compared to dose as MVEC. So most of the center I also see they gave dose dense MVEC. Still, I hadn't used, but I will try to use.
Yeah. Okay. Thank you, Dr. Rohit.
My pleasure, sir. My pleasure.
Yeah, yeah. So for this next session, I think this is the extra sponsored session. For this, I invite Dr. B.S. Ankit, who is the consultant medical oncologist at Renova Cancer Center at Rajasthan Hospital, Jaipur, and so he will deliver the talk on this the newer updates in this management of first line biliary tract cancer. So over to you, Dr. Ankit.
Good evening, all. Thank you, Devesh sir, once again for giving this opportunity and AstraZeneca. Just let me share my slides and I'll start very quickly.
So I think Dr. Ankit, time is very limited. I think
Yeah.
already
Yes,
10
sir.
minutes. Okay.
So are my slides visible, sir?
Yeah. Your slide is visible.
Yeah, I'll just discuss about newer updates in the management of first line metastatic or locally advanced inoperable biliary tract cancers. So the estimated incidence with the cancer registry in 2020 is 31,000 for biliary tract malignancy, including gallbladder, which is in Globocan 2020 data, it is around 20,000. So highest incidences we found in either Assam and Delhi, and 90% of the biliary tract malignancy either diagnosed in unresectable or advanced malignancy. Till date, before the introduction of IO, the standard of care was gemcitabine with cisplatin, giving a median overall survival less than 1 year and 5-year OS rates of less than 10%. So coming straight away to the current management of advanced biliary tract. So in 2010, after the ABC2 trial, which compared the introduction of cisplatin to the gemcitabine, showed a median overall survival benefit in almost around more than 400 patients, which was 11.7 versus 8.1 months, and as well as the PFS benefit. So it became a standard of care. This is the match pair analysis done in the Tata Memorial by Anant and Vikas sir, which compared more than 300 patients between gemcitabine with cisplatin versus gemcitabine with oxaliplatin, and they found that both are having almost similar overall response rate, and median EFS and median OS was also similar. There was a difference in the tolerability. Peripheral neuropathy and hepatotoxicity was little higher in oxaliplatin arm, and the cardiac dysfunction and renal dysfunction, including the hematological toxicity, was slightly higher in gemcitabine cisplatin arm. So this is till 2022. The gemcitabine cisplatin is the standard category 1 indication by NCCN, and 5FU with oxaliplatin or capecitabine with oxaliplatin, gem cap or gemcitabine with oxaliplatin is other recommended regimens. So introduction of IO, there was initially one trial in 2020, and this is the Topaz trial published in 2022 in NEJM, which is a phase 3 randomized double-blind study of introduction of durvalumab with gemcitabine cisplatin in patients with advanced or unresectable biliary tract cancer. So coming to the inclusion criteria, either locally advanced or metastatic biliary tract, intrahepatic cholangiocarcinoma, extrahepatic cholangiocarcinoma, and gallbladder cancers, or those the patient who are recurred after 6 months of surgery or after the end of adjuvant therapy, having a bilirubin of less than 2 of the upper limit, ECOG status either 0 or 1, or at least having one measurable lesion by the RECIST criteria. Around 685 patients were there, and randomized between durvalumab with gemcitabine cisplatin up to 8 cycles versus chemotherapy alone, followed by a placebo or a durvalumab maintenance in the IO plus chemo arm. So primary endpoint was overall survival, and secondary endpoint was progression-free survival, overall response rate, duration of response, patient-related outcomes, safety, biomarkers, and pharmacokinetics. So going to the demographic and baseline characteristics, median age was in both the arms was 64 years, 50% patients were female, almost 55 to 58% of the patients were Asian. ECOG status was 0 in 50% and 1 in rest 50% of the patients. 55% patients were intrahepatic cholangiocarcinoma, followed by 25% of gallbladder cancers, and 19% patients, 18 to 90% patients were extrahepatic cholangiocarcinomas. Almost 80% patient were initially unresectable, and 20% patient had a recurrence after surgery or adjuvant chemotherapy. Mostly were metastatic, up to 88%, and 11 to 15% patients were locally advanced, and both the arms baseline characteristics was comparable. MSI was not done in almost 50% of the patient, and rest 50% of the patient it was stable. PD-L1 expression was more than 1% in almost 60% patients, and negative in rest of the 30%, and was not done in rest 10% of the patients. The patient, almost 99% of the patient received treatment. After the data cutoff time in IO plus chemo arm, there was 18% patients still ongoing on the treatment, versus chemo alone arm, it was only 5.8%. Reason for the discontinuation was mostly was radiological progression in 56% in combination versus 69 in chemo alone arm. Coming to the subjective disease progression, it was 12 and 13%, again quite comparable. And adverse events were 5.9% in combination and 5.3 in chemo alone arm, which is again quite comparable. And the patient received 40% of the patient received cytotoxic chemotherapy in subsequent line of treatment. So coming to the Kaplan-Meier OS curve, so a median OS overall survival was 12.9 versus 11.3 months, and 2-year OS rates was almost double than the chemo alone arm, which is 26% versus 11.5 months. So it is the only IO which shows a sustained and durable OS benefit even after 2 years. Coming to the forest plot, all the patients across all the subgroup was benefited with the combination arm, and highest benefit was seen in either extrahepatic cholangiocarcinomas, those who were having a locally advanced disease, Asian population, or PDL1, where PDL1 was more than 1%. Coming to the PFS Kaplan-Meier curve, the median PFS was 7.2 versus 5.7 months, and the 12 months PFS was again 3 times in combination arm, which is 16% versus 6% in chemo alone arm. Again, the PFS had a similar kind of subgroup benefit, and all the patient benefited in PFS as long as PFS was concerned. Overall response rate was 26 versus 18%. The patient who were responded continued to respond. 26% of the patient continued to respond after a 1-year therapy, which compared with the 15%, and the disease control rate was 85 versus 82%. So those the patient who had a complete or partial response had a separation around 15 months, and 2-year OS was 40% versus 20% in placebo plus chemo arm, which is again double than the combination arm, half in the combination arm. And to those the patient who are having a stable disease, the graph started separating as soon as 6 months, and 2-year OS was 10 months versus 20 months in the combination arm. And those the patient who had a progression at 3 months did very bad, and 1-year OS was quite comparable, 18 months versus 19.2 months. So coming to the treatment related adverse event, in grade 3, grade 4 treatment related adverse event was 62% and 64% subsequently, and treatment related treatment related adverse event leading to the discontinuation was 8% in combination versus slightly higher 11% in the chemo alone arm. So this is the adverse event 75% grade 3 adverse event, and 77% in the chemo alone arm, and mostly either anemia, thrombocytopenia, and neutropenia was the most common grade 3, grade 4 event, which was again related to chemotherapy and which was easily manageable. Slightly higher adverse event in the terms of fatigue, which is quite common with the immunotherapies, was seen in the combination arm. Other than that, all other side effects were quite comparable or slightly higher in the chemo alone arm. So coming to the immune related adverse event of the combination arm, it was 2.4% grade 3, grade 4 compared to 1.5% in chemo alone arm, and highest incidences was either dermatitis or pneumonitis, hepatic events, or colitis or diarrhea, or type 1 diabetes mellitus, and which was again quite manageable. Those the patient who had immune related adverse events had a median OS of 17 months versus 14 months with the hazard ratio 0.66, and those the patient did not had any immune related adverse event had a median OS of 12.6 versus 11.4 with the hazard ratio 0.83. So combination arm was associated with OS benefit in placebo versus the placebo plus chemo arm, irrespective of immune-related adverse event happened or not. So after this trial, now the NCCN category 1 indication has been added with the durvalumab along with the gemcitabine cisplatin arm, and can be considered as category 1 in unresectable and metastatic biliary tract malignancy. So after 13 years of ABC2 trial, now we had again phase 3 trial which was positive, and which shows a category 1 indication by the NCCN guidelines. So TOPAZ is the first global phase 3 trial to report a positive result with the combination of immuno with chemo as a first line treatment for advanced biliary tract malignancy. Can and should be considered as a new standard of care, which showed a clinically meaningful and statistically significant OS benefit. Biomarker, either PDL is positive or not, MSI is high or not. The benefit was there in all across subgroups of the patients. Safety, there was little or no additional toxicity with the durvalumab, which was again quite comparable, and now DCGI approval for the 1500 mg dose along with the chemotherapy is granted. So this is the prescribing information, and I thank you all. Any question I would like to ask?
Thank you, Dr. Ankit. So just my query. So are you using this molecule as upfront in the metastatic biliary setting?
One patient only, sir, just recently.
Link between two meetings. Sorry for the delay. So the topic given to me today is regarding the advancement in the urothelial cancer. So urothelial cancer is sort of a lethal cancer. It is the 17th leading cause of cancer in India and the 21st leading cause of mortality in India. So the problem in the US, most of the cancer, you will look almost 80% is localized. But in India, we get 50% which is advanced or metastatic, and only around 50% is non-muscle invasive. That's the problem here. We are not able to diagnose early. That's we have a high mortality with this disease. And this is the TMS data, which clearly showed that the Indian males and females, it's the prevalence of bladder cancer is very, very high, and especially more predominantly Indian males compared to females. So looking at the overall survival, 5-year overall survival for a stage 4 bladder cancer is very poor, is less than 8%. And even if the patient undergoes surgery, 50% are likely to relapse with the metastasis, and ultimately these patients do very poorly. So these are the guidelines. Standard treatment for a metastatic urothelial cancer is platinum-based therapy. So standard is to be cisplatin or carboplatin. So it's based on all these criteria, whether the patient has a good PS, doesn't fit in a heart failure class, GFR is better, no audiometric ear loss, or no peripheral neuropathy is there, then yes, cisplatin is the choice of drug. Otherwise, we combine with carboplatin. So we look at all these multiple trials of combination of platinum. We see there are good response rate because platinum is the backbone, and we see a good PRs, almost 80% response. Patient responds to platinum in the upfront therapy. But the problem is they don't have that much sustained response. Patient initially has a good response, almost 80% achieves a response, but the OS is limited. We see multiple studies with the chemotherapy, the OS is around 13-14 months, so around a year. So what strategies which we are doing now to extend that survival in metastatic setting? So multiple initial phase 3 failed study of immunotherapy has been done with pembrolizumab, atezolizumab, and a durva combination. All of these studies gave upfront started with a chemo combination, and all of these studies failed to show any improvement in overall survival and PFS, though it was slightly better, but none of the studies showed a significant overall survival improvement. So then came the strategy, which was taken by Javelin bladder study, that they initially gave a chemotherapy combination, achieved a response, and for the patients who didn't achieve a response, achieved a response as a CR, PR, or stable disease, were then taken for IO maintenance. So based on this, we look at that if the standard first line treatment, NCCN guidelines clearly show standard treatment is to give chemotherapy followed by avelumab maintenance therapy, whether the patient is taking carboplatin or cisplatin combination. So what was the rationale behind this by not combining with chemotherapy and giving IO after chemotherapy? So the rationale in particularly in urothelial cancer was that chemotherapy will decrease the tumor burden to achieve disease control and increase the immunogenicity of the tumor microenvironment, where those patients are more likely to respond to immunotherapy, which was because the microenvironment might not have been that much immunogenic in the baseline. And as the tumor burden decreased, those immunogenicity increase. So maybe those patients are more likely to respond to immunotherapy rather than giving upfront a combination. So this is the Javelin phase 3 bladder study. Patient of stage 4 advanced urothelial cancer are given 4 to 6 cycles of cis or carbo with gemcitabine. Patient who achieved either CR, PR or stable disease were then randomized to avelumab or best supportive care. The primary endpoint was overall survival. Median age was 68. It's a disease of old age. Majority were males. Good performance status. Almost 50% of the visceral metastasis. Almost 50%, 50-50 difference of use of cisplatin and carboplatin as seen in real life studies as well. So now, as clearly shown that giving avelumab improves the median overall survival by almost 8 months. It's 24 versus 15 months. Almost 50% of patients were alive at 2 years, which is a big thing for a bladder cancer in which patients usually don't do that much well. Even if you look at the PFS at 2 years, the 25, almost a quarter of patients were still on the first line treatment compared to just 7% the patient on best supportive care alone. So if you look at starting from when the chemotherapy was started, so almost these patients achieved overall survival of around 30 months, 2.5 years, as compared to 20 months the patient who just took chemotherapy in the first line. So based on this, all the guidelines now recommend that we give first line cisplatin carboplatin combination, followed by Babencio maintenance, and when they give these subsequent lines of therapy, we will achieve a median OS of around 30 months as shown. If we don't use it, then usually we give first line therapy, wait for the patient to progress. Then we give second line, we can give immunotherapy in the second line single agent, but we achieve OS of around 20 months. So 10 months is a big overall survival difference, which can be achieved by using avelumab maintenance upfront rather than waiting for the patient to relapse. So it's clearly shown, I already told you, almost on the older studies, it shows that only 20% of patients were alive, but now around 50% of patients are alive at 2 years. So more than twice the improvement has been seen by addition of immunotherapy for this subgroup. And this benefit was seen in all the subgroups, irrespective whether the patient was PDL1 positive, any kind of whether cisplatin, carboplatinum used, whether the patient has baseline visceral metastasis, all the patient had a good response. Whether patient had a good response, CR, PR, or stable disease, all patients responded to immunotherapy. And if you look at the change in this FBI score, quality of life, basically total score, there was not any difference whether we use immunotherapy. There was not any deterioration in the quality of life as well. So if you look at now particularly Asian subgroup, which is around 73 patients in each arm in this trial, the results are more or less similar. We see at 24 months, 60% of patients are still on alive with a median OS of 28.7 months compared to 18 months in the chemotherapy arm. PFS similarly was almost 3 times increased, 5.6 months versus of 1.9 months. So Asian patients were from Japan, even from India. So this drug works even in Asian population as well, which is usually underrepresented in most of the studies. So we have data to show that we can use also this drug with a good benefit. We look at the long-term adverse events. We look at grade 3 or more adverse events, there were around 50%. Not any major adverse event or new adverse events, which we are now well versed with what kind of adverse events can happen with immunotherapy. We know what can happen, though there were discontinuation, around 10% of patients discontinued because of adverse events. There were 3 deaths, but not any major differences compared to any other immunotherapy study. So what we do in the second line, so we have given the first line treatment, patient immunotherapy in combination with immunotherapy and a chemotherapy. Second line, multiple options are now coming up. multiple novel drugs have come up in the second line therapy, particularly in urothelial cancer, and ADCs have particularly come in a big role, like this enfortumab vedotin, secukinumab is also now used, adafatinib, or we don't have these, we don't have any of these. So eventually we use chemotherapy. So this is the subsequent therapies which were used in this Javelin studies. For most of the patients who are not on the immunotherapy arm, almost majority of those patients eventually received around, 3/4 of the patient received immunotherapy in the second line and some novel drugs as well. Compared to the patient with the immunotherapy arm, they received mostly chemotherapy. So there were good number of patients were able to take immunotherapy in second line, but still that benefit was not seen when we give the immunotherapy in the first line setting. The similar thing, summary of all this, what kind of therapy was given in the immunotherapy arm. So now looking at these novel agents which we are now getting. So ADCs like enfortumab and secukinumab has shown good response, and now studies are ongoing in the first line with the combination. Adafatinib, which is used for FGFR selected patient, which is around 10 to 20% in the bladder cancer. It shows a very good response rates and overall survival of almost a year in the second line setting, which is a great data, I will say. And we will have more and more of these drugs are, been studied in the first line, the combination, the randomized studies, and we might also get these drugs in the near future. So the standard treatment for nowadays, cisplatin eligible, 4 to 6 cycles of gemcisplatin followed by avelumab. If patient is not cisplatin eligible, we can give a carboplatin instead of cisplatin. If patient is not at all platinum eligible, either we give best supportive care or pembrolizumab also can be used. As I already told you, first line using Babencio maintenance gets us a overall survival of almost 2.5 years. Just using platinum and then giving immunotherapy in second line, we get a overall survival of 1.5 months, and just chemotherapy gives us a around if we had used an upfront combination, which were used in multiple studies of so-called failed phase 3 trials of almost all other immunotherapy except avelumab, they showed overall survival of around 1.5 years. So basically, so whatever we have, the best result we got with avelumab, and it showed a remarkable improvement. That's what I have to say. Thank you.
So, thank you, Ankur. So, do you routinely use the maintenance avelumab after the 4 to 6 cycle of platin plus gemcitabine?
If patient can take, then yes.
Yeah. Okay. So, I think you convinced this Javelin trial.
Yes, definitely. It's shown a very good result because the difference was this in maintenance, and it picked up some patients which are because if we compare to other studies, the all phase 3 trials which have failed with pembrolizumab and all those studies. So there were 10 to 20% of patients who are going to fail whether you give immunotherapy or not. So those patients are tend to fail. But because of this maintenance and switching maintenance, some 10 to 15% of subgroup, which was eventually not going to receive any treatment at all and might have responded to just immunotherapy, that benefited, and particularly that subgroup, drove the result in favor of avelumab.
Suppose if you have in metastatic setting, we have used the 4 to 6 cycle of platin plus gemcitabine, and now not is affordable for this IO, basically Nivo or IV. So what you do? So do you continue this cycles or just a drug-free interval in your clinical practice?
If patient is asymptomatic, not that many side effects, I will continue the drug.
Okay.
If patient becomes too much symptomatic, then I will stop and restart when the symptoms appear.
Okay. So in the patient to patient, it will vary.
Because I remember giving patient around 11-12 cycles I have given to a patient. Patient eventually progressed, but didn't develop any side effects. So I continue.
Okay. So thank you, Dr. Ankur, for this wonderful talk, and I think very informative session. So thank you, Mark, and thank you, Dr. Ankur, for this session. For this next session, I will invite Dr. Kapil Goyal from Delhi. He is Associate Consultant in Medical Oncology Department at Action Cancer Hospital, Delhi. And he will give a talk on this abstract on rectal cancer. So over to you, Dr. Kapil Goyal.
Good evening, everyone. I hope I'm audible and visible to everyone.
Yeah.
Yeah, okay. So good evening, everyone. First of all, I would like to inform that now I have joined Rajiv Gandhi Cancer Institute in capacity of consultant now. I used to work in Action, but now I have joined Rajiv Gandhi Cancer Institute, Delhi. Coming to my talk, so today I will be presenting about the prospect trial, which was published in NEJM this year, and also it was presented in ASCO GI 2023. So the bit of summary about the rectal cancer. So most intermediate risk rectal cancer patient can receive curative intent treatment without pelvic chemoradiation. That is the bottom line of everything. So going into the detail. So, as we know that globally, approximately 8 lakh new rectal cancer are diagnosed, and pelvic chemoradiation with either 5-FU or capecitabine. It reduces the local pelvic recurrence, which is a highly morbid outcome. And now neoadjuvant pelvic chemoradiation is the standard treatment since almost like 30 years now. Previously, we were using infusion 5-FU with the radiation, but now I think in most of the places, most of the medical oncologists use capecitabine, talbot along with the radiation. So this has been the standard approach since many years. The pelvic chemoradiation, which includes 50.40 gray of radiotherapy with concurrent 5-FU or capecitabine, followed by 8 weeks of recovery. Then surgery is done, total mesorectal excision, which needs approximately 1 week of hospitalization. And after 6 weeks of gap, we start on adjuvant chemotherapy, which could be either capox or folfox for a total of 4 months. This has been the standard of care so far for many years. However, because of the pelvic chemoradiation, we have seen patients coming up with many long-term toxicities like impaired bowel, bladder, and sexual dysfunctions, increased risk of pelvic fracture because of the radiation, and second malignancy because the radiation is being given in the pelvic area. So bone marrow is depleted sometimes, and patient present with pancytopenia when we give chemotherapy. Infertility and premature menopause is a problem in younger patients, and increasing diagnosis of rectal cancer before age 50 years of age. So, but however, over the past almost 1 decade, many things have changed. Now we have effective chemotherapies like FOLFOX, the surgical technique, total mesorectal excision. Now also we are doing it very differently. In most of the patients, we are able to preserve the sphincter. And because of the screening programs available in many countries now, fewer T4 and symptomatic tumors are diagnosed, which were very high in the earlier time. And pelvic MRI is now frequently available, and it used most commonly for the accurate staging of rectal cancer. So just a second. Yeah. So the prospectral hypothesis is was generated after a pilot study in which the patient who were treated with neoadjuvant FOLFOX and who had good response, they could skip radiation, and none of those patients had developed local recurrence. So being motivated by this, so the scientists divide this prospect trial in which the hypothesis was that neoadjuvant chemotherapy with FOLFOX and only selective use of pelvic chemoradiation will be non-inferior to routine use of pelvic chemoradiation for locally advanced rectal cancer. So the design was that they recruited 264 practicing sites in the USA, Canada, and Switzerland from 2012 to 2018. So who were the patients that were eligible? So patient who had rectal cancer of clinically T2 node positive or T3 either node positive or node negative. So they were randomized in 1:1 ratio to the standard control arm, that was pelvic chemoradiation with 50.4 gray in 5.5 weeks, and experimental arm that was neoadjuvant FOLFOX for 6 cycles. And only if the response was poor, which was less than 20% of the tumor shrinkage after 6 cycles of FOLFOX, or FOLFOX was not tolerated because of the side effects, only those subset of the patient proceeded to get the chemoradiation. The important thing is that the T4 tumors and patients who had heavy node more than 4 pelvic nodes and patients who had distal tumors were who required abdominoperitoneal resection, they were all excluded from this trial. So the randomization was such that the control arm pelvic chemoradiation, they underwent pelvic chemoradiation followed by surgery and then adjuvant chemo. While patient in the experimental arm received 6 cycles of FOLFOX and then restaging were done. So patient who had more than 20% response proceeded with the surgery without any radiation followed by adjuvant chemotherapy. However, patient who received who had less than 20% of the response or somehow could not receive at least 5 cycles of FOLFOX, they were switched to the pelvic chemoradiation and then they proceeded for the surgery. After the surgery, those patients who had margin positivity that means who did not have R0 resection, also received post-operative chemoradiation. A few things were at the discretion of treating physicians, like for the staging, restaging particularly, people could have used pelvic MRI as well as endorectal ultrasound. For radiation, IMRT or external beam radiotherapy either could have been used as per the discretion of the treating institute. For the concurrent chemotherapy, capecitabine or IV-5FU, anyone could have been used. For the surgery, open or laparoscopic TME could be used, and the adjuvant regime could be either FOLFOX or CAPOX as per the discretion of treating institution. So inclusion criteria, as I've already discussed, the clinical list is T2 node positive or T3 node negative or node positive, both are for fine. Chemo radiation was indicated who were candidate for a sphincter sparing surgery. Important was the exclusion criteria. So tumor requiring an APR, they were mostly the tumor which were within 3 centimeter of the anal verge, clinically T4 tumor, and the pelvic lymph node more than 4, so and 2 tumor, they were all excluded. So very heavy burden disease were mainly excluded. So locally advanced tumor with a low burden of disease were only included in this trial. Study endpoints were primary endpoint was DFS, and secondary endpoints were local recurrence, overall survival, R0 surgical resection, complete pathological response, and toxicity and quality of life. So non-inferiority hypothesis, if we talk about, so it could be claimed if the upper limit of two-sided 90.2% confidence interval and the hazard ratio did not exceed 1.29. In my opinion, 1.29 is a very huge margin for a non-inferiority trial. Typically, I feel 1.1 to 1.15 is a suitable non-inferiority margin. 1.29 is still a wide margin, and which corresponded to an absolute difference in 5-year DFS of less than 5%. So also for a non-inferiority trial, DFS benefit of 5% is quite a lot. So I feel personally that there was this statistical overestimation of the non-inferiority. So superiority could be demonstrated if hazard ratio was less than 1. Non-inferiority could be detected between 1 and 1.29. And while inferiority would be detected if the hazard ratio confidence interval exceeded 1.29. So these are the baseline character in two arms, the 585 in the FOLFOX arm and 543 patient in the chemoradiation arms. In either arm, 2/3 of the patients were male, and average the median tumor location from the anal verge was 8 centimeter in both the groups, and 84% patient underwent MRI staging. And more than half of the patients in either group, but actually T3 node positive, with very few patients being actually T2 node positive. If we look at the efficacy, then this is the DFS rate at the 5-year, which was 80.8% in the experimental arm versus 78.6% in the chemoradiation arm, with a hazard ratio of 0.92 and confidence interval exceeding 1.14. So which demonstrated the non-inferiority of FOLFOX strategy after a median follow-up almost 5 years. So given talking about the same outcome in a statistical endpoint, we can see that the hazard ratio is lying at the left side of 1, which is the 0.7, so 0.74, so sorry, 0.92. So at adjusted hazard ratio was 0.90, so it can be proven that the non-inferiority criteria was met and the neoadjuvant FOLFOX therapy was non-inferior to pelvic chemoradiation. I would also like to mention the percentage of patients who in the chemotherapy group who proceeded to receive neoadjuvant pelvic chemoradiation was 9% in this arm, either because of the decreased less than 20% response after FOLFOX or due to intolerance to FOLFOX. So 10%, only 10% of the patient proceeded to get neoadjuvant pelvic chemoradiation in the FOLFOX arm. So local recurrence free rate at the 5-year, it was respectively 98.2% in the FOLFOX arm and 98.4% in the chemoradiation arm after 5 years of follow, which is the same. And looking at the OS data after 5 years, so chemoradiation arm and FOLFOX arm, in both the arms, the almost 90% of the overall survival was seen, which was a impressive result after median follow-up of 6 years, and there was no difference. And if we look at the R0 rectal resection in both the arms, the 99% patients in the FOLFOX arm and pelvic chemoradiation arm, 97% of the patient achieved R0 resection. Low anterior resection rate was 98% in either arm. Pathological complete response was 22 and 24% in the arms, which was also good. And the positive radial margin was seen in 1.2% of the patient in the FOLFOX arm and 1.5% in the pelvic chemoradiation arm. The 1.2% patient who were positive radial margin in the FOLFOX group, they and had not received neoadjuvant pelvic chemoradiation proceeded to receive adjuvant radiation after the surgery. Adjuvant treatment, 82% patient in the either arm received adjuvant chemotherapy, and median duration for randomization to last dose of post-op therapy was similar in both the arms, which is 35 weeks. 9% of the participants who were randomized to FOLFOX received neoadjuvant chemoradiation, as I discussed already, because the restaging demonstrated clinical response less than 20%, or they did not tolerate at least 5 cycles of the FOLFOX. So if you look at the toxicity pattern in the neoadjuvant side, we see that the grade more than 3 adverse event were much higher in the FOLFOX arm, because obviously the high dose of chemotherapy was going on. So 41% patient had some kind of grade 3 adverse event, while only 23% patient had grade 3 adverse event in the neoadjuvant arm. However, if we look at the adjuvant part, then because the chemoradiation arm had received prior radiation therapy, so 40% of patient had in the adjuvant arm grade 3 reactions, while only 25% patient had in the FOLFOX arm. And notably, the diarrhea was more in the radiation group and neuropathy was more in the FOLFOX group. And during adjuvant treatment, both the diarrhea and the neuropathy, both were more in the RT group. So this is the detail of adverse event in both the arms. So if we look, the diarrhea was only 6% in the neoadjuvant time. Diarrhea was only 6% in the FOLFOX arm, while it was 20% in the chemoradiation arm. And patient reported severe adverse event at the 12-month. If we see, the neuropathy also was higher in the chemoradiation arm. If we look at the quality of life, we see the overall health-related quality was showing a somewhat upward trend with the FOLFOX. The quality life was better upward, but it was not statistically significant, while bowel function and the sexual dysfunctions were better with the neoadjuvant FOLFOX arm rather than the control arm. So there were many limitations because this trial was conducted from 2012 to 2012 to 2016. So it had excluded high-risk patients like distal T4 tumor, multiple enlarged node, which make up quite a lot of our patients even these days. And not all patients, 80%. Sorry?
Sir, please conclude.
Yeah, so not all patients had MRI staging. Approximately 10 to 15% patient had not been staged with the MRI, and we may still be over-treating some patients. And there were many caveats because while from 2015, 2016 to now in 2023, when this trial was actually published, newer approaches have emerged, mainly speaking of the short course radiation therapy and total neoadjuvant therapy, which have now become sort of much more widely practiced approaches these days. And also with the advent of dostarlimab, the non-operative management, and even with in MSI high tumors and non-operative management as per with the neoadjuvant chemoradiation. So these are also coming into the limelight. So these approaches were not explored, and shorter course of adjuvant FOLFOX is now given. So these were the main caveats. So to conclude, the neoadjuvant FOLFOX with only selective use of pelvic chemoradiation, it is a safe and effective treatment option for patients with clinically T2 node positive disease or T3 node positive or node negative rectal cancer. Thank you.
Thank you, Dr. Kapil.
Questions.
Yeah, thank you, Dr. Kapil. So is it practice changing? So can we use only and only chemotherapy in the locally advanced rectal cancer?
Honestly speaking, sir, I'm hesitant to put this trial in my routine practice. We are not following this because there are very limitations. Because first of all, the staging and restaging, both are not accurate, even with the MRI or endorectal ultrasound. So that is a very subjective thing. I mean, the restaging has to be very accurate in this, and the further follow-up for patient who did not have this who did not undergo radiation. For those patients, we need proper follow-up with the MRI. So that thing is somehow not possible. So I don't think that this is practice changing. Rather, we are also moving towards a total neoadjuvant therapy and organ preservation approaches, which are more encouraging. And so we are moving towards the total neoadjuvant and organ preservation.
So thank you, Dr. Kapil, for this informative session. So for the next talk, I invite Dr. Ankur Varshney from Delhi, and he is medical oncologist at Medanta Gurugram, and his talk on abstract metastatic pancreatic ductal adenocarcinoma. So over to you, Dr. Ankur. I think time is very short. Please do complete within 10 minutes. I think your voice. Please unmute.
Thank you, Dr. Devesh.
Yeah.
And I will try to summarize it in a crispy way. Okay. So this is a study regarding the use of naliferox. Naliferox is the use of liposomal irinotecan. Now, what forms the basis of this study is the earlier studies. Earlier, we have seen in the studies such as Napoli 1, in which liposomal irinotecan was used in patients of metastatic pancreatic cancer after the use of gemcitabine as a first-line therapy. And this study has shown advantage that liposomal irinotecan can be used along with a combination of 5-FU and leucovorin in patients of metastatic pancreatic cancer after they have progression on gemcitabine-based therapies. Later on, Napoli 2 study was done, which was done in a advanced biliary tract cancers, which again has showed the benefit. And now Napoli 3 study has come on, which is including a direct comparison of combination of oxaliplatin, leucovorin, 5-FU, along with liposomal irinotecan, and its comparison is done with the standard of care in pancreatic cancer, that is the using of gemcitabine-based therapies. So coming to the background of the studies, this study is conducted globally at a community level.
Slide is not moving. Slide is not moving.
Slide is moving on my screen.
Sir, there is no moving here.
Are they moving now?
Sir, please move.
Yes.
Moving?
Not moving, sir.
Can you take the control of the screen share then?
Yes, sir, yes.
So this was a trial done at various international centers, including 6 sites in Canada, United States, Brazil, Australia, South Korea, and majority of the European countries. Can we move to next slides? So the inclusion criteria in this included patients who were younger, who were older than 18 years of age, had a confirmed diagnosis of pancreatic ductal adenocarcinoma. They were treatment name, not treated. Metastasis was diagnosed. At least one measurable lesion was there as per CT MRI, as per RECIST criteria. They have a preserved performance status of 0 or 1, and the patients were diagnosed before inclusion in the trial within a period of less than 6 weeks. So these patients were randomized on the basis of ECOG performance status, reason involved, and liver mets into 2 categories. The one was the study arm, that is naliferox. This includes the combination of liposomal irinotecan at 50 mg per meter square, 5-FU at 2400 mg per meter square, leucovorin at 400 mg per meter square, and oxaliplatin at 60 mg per meter square. Now, the dose of oxaliplatin which is used in this study is typically lower than that which we used in modified fall-free NOx regime. We use the dose of 85 mg per meter square, and this chemotherapy regime was used every 15 days. Then the other arm, which is the standard of care, it was combination of a gemcitabine and nab-paclitaxel. Gemcitabine was used at 1000 mg per meter square, and nab-paclitaxel was used as 125 mg per meter square at day 1, 8, and 15 of a 20-day cycle. And after this, the tumor assessment was done every 8 weeks as per RECIST criteria. Treatment was done until either there was disease progression, or there was any unacceptable toxicity, or there was any patient withdrawal due to any other reasons. Adverse events were noted, and there was follow-up of every 8 weeks with every patient until the end. Next slide. Can you move to next slide? So coming to the study endpoints, the primary endpoint of this study is overall survival. Moving to previous slide. The secondary endpoint was either progression, survival, and overall response rate as per the investigator. Exploratory endpoints were divided as health-related quality of life index and biomarker assessment using CA 19.9 levels. Statistical analysis was used using stratified log-rank test, and it was observed in intent to treat population in a stepwise hierarchical test for efficacy. P value was claimed for a final analysis to be less than 0.048. The first patient was enrolled in February 2020, and the last data cutoff of evaluation was used in July 23, 2022. Average median follow-up in this study was 16.1 months. Next slide. So coming to the patient population, in this, if we see the patient who discontinued treatment, the majority of the patient in Nalifox, at 85% of the patient discontinued treatment in the Nalifox arm, while a significant more population, 96% population in gemcitabine and nab-paclitaxel arm discontinued treatment. The patients who continued our 11% in the Nalifox arm and only 2% in the gemcitabine nab-paclitaxel arm. If we go with the response assessment, there was progressive disease at the end of the treatment in 48% of the patient population with the Nalifox arm, in 45% with the gemcitabine and nab-paclitaxel arm. Adverse events were reported in 14% only population in Nalifox arm, while it was reported at high in 24% of the patient population in gemcitabine and nab-paclitaxel arm. Death was reported more in the Nalifox arm, while it was 8.4%, while it was 6.7% in the gemcitabine and nab-paclitaxel arm. Next slide. Now coming to the baseline characteristics of these, we see the median age in both the cohorts was 64 years and 65 years. Majority of patients were, it was a male predominance study. On both the cohorts, there were male predominance. Majority of the population were whites. They have an ECOG performance status preserved with 0 and 1. Maximum patients had greater than 3 sites of METs in the Nalifox arm, while it was in gemcitabine and nab-paclitaxel arms. Patient preference was there slightly, with majority of the patients were in having a one site of METs only. Liver METs were present in both the arms in 80% of the patients. Majority of patients were from the West European countries, and the main tumor location was either in the tail of pancreas in majority of these patients. Baseline CA 19.9 was raised in majority of the population, approximately 80% of the patient population. Prior chemotherapy, so it was not, chemotherapy was not there, but any form of radiotherapy or surgical procedures were permitted, which included 5.7% in the Nalifox arm or 7% in the gemcitabine nab-paclitaxel arm. And the randomized session was done within 6 weeks. So median duration of randomization was 3 weeks in the Nalifox arm, and it was 3.6 weeks in the gemcitabine nab-paclitaxel arm. Next slide. So coming to the end point, we see the median overall survival in the Nalifox arm was 11.1 months, while in the patient population undergoing gemcitabine and nab-paclitaxel, the median overall survival was 9.2 months. So at the end of 1 year, we see that there were 45% of patients surviving in the Nalifox arms. It was 39.5% patients surviving in the gemcitabine nab-paclitaxel arm. At the 2 years, 18 months overall survival, the survival percentage was 26% in the Nalifox arm, while it was only 19% in the gemcitabine nab-paclitaxel arm. Next slide. Now, when we see this forest plot analysis, we see this Nalifox arm was showing better in every aspect as shown by these diagram, either the presence of liver mets or in the presence of metastatic sites, especially when metastatic sites are more in number, the drug was found to be more beneficial as compared to the gemcitabine nab-paclitaxel arm. We see the recent difference in both, either in the North America or in the rest of the world. The subgroup was better shown in the Nalifox arm. In the patient population who had increased chances of having a baseline CA 19.9, probably because of the larger number of METs, this has shown a good benefit as compared to the gemcitabine nab-paclitaxel arm. and the benefit was strictly more found in the patient population who is 65 greater than 65 years of age. Now this is something that we do not consider, because patients having age greater than 65, we usually found that they have performance status poor, and we usually prefer a better tolerated regime in this arm is gemcitabine and nab-paclitaxel, which we found in our clinical practice. Next slide. So we record the PFS benefit. The PFS benefit in the nalifurox arm was 7.4 months as compared to the gemcitabine nab-paclitaxel, which has a PFS of only 5.6 months. Now we see the hazard ratio of this is 0.69, which ends in a significant p-value of less than 0.001. At that 12 months, the patient population in the nalifurox arm was 27.4 months, while in gemcitabine nab-paclitaxel arm only 14% patient had a PFS benefit. Next slide. So when this PFS subgroup was analyzed and forest plot was put, we see this benefit was across all the every cohort, and this was irrespective of the presence of liver mets, number of mets, location of tumor, baseline CA 19.9, and age difference. Next slide. So now we analyze the exploratory endpoints, and we find that overall response rates were 41.8% in the nalifurox arm, while it was 36.2% in the gemcitabine nab-paclitaxel arm. Complete response in both arms were pretty low as expected from metastatic pancreatic cancer. It was 0.3% in the arm. Partial response was 42% in the nalifurox arm, while it was 36% in the gemcitabine and nab-paclitaxel arm. Stable disease was 25% in nalifurox arm. It was 26% in the gemcitabine and nab-paclitaxel arm. While progressive disease was found at 10% in the nalifurox arm and 15% in the gemcitabine nab-paclitaxel arm. At the end, 22% patient population was not available with the patient population of nalifurox arm, while 23% patient was not available in gemcitabine and nab-paclitaxel arm. Disease control rate was slightly better in the nalifurox arm. It was 67.6 months, and it was 62% in the gemcitabine nab-paclitaxel arm, while duration of response, which we find that the response rates were better in the nalifurox arm, they were sustained over time, and median duration of response was 7.3 months in the nalifurox arm, while it was only 5 months in gemcitabine nab-paclitaxel arm. Next slide. So coming to subsequent anti-cancer therapy, in the 50% of patients were in the nalifurox arm still remained had a preserved performance status and were able to go a second line subsequent chemotherapy, while the performance status in the gemcitabine nab-paclitaxel arm were preserved in the 54% patient population, and they were able to go second line chemotherapy. Surgery and radiotherapy was not achieved in maximum of these patients. Next slide. Now we see if we study the overall adverse events. Now it was comparable in both the arms. More than grade 3 adverse events were 87% recorded in the non-free arm, while it was 86% in the gemcitabine and nab-paclitaxel arm. Serious adverse events were noted in 54.3% patient population in the test arm, while in the control arm it was 51.5%. And treatment-related adverse event which led to death were 5.9% in the test arm, but it was 6.7% in the gemcitabine nab-paclitaxel arm. So median duration of treatment was 24.3 weeks with nalifurox, while it was only 17.6 weeks with gemcitabine and nab-paclitaxel. Next slide. So we analyzed the side effects. As expected, the nalifurox being an extensive regime, the most common side effect was neutropenia and febrile neutropenia. We see a difference that neutropenia was more pronounced, approximately in 50% of population, but febrile neutropenia was only possible in 3% of patient population. Coming to the grade 3 and 4 neutropenia, it was 23% with the nalifurox arm, while it was 2.4% in the with the febrile neutropenia. The similar incidence of neutropenia was seen in the gemcitabine and nab-paclitaxel arm. 50% of patients had neutropenia, while febrile neutropenia incidence was pretty low. It only was 3% of patient population had to face febrile neutropenia. The other side effects which was quite common, it was anemia and thrombocytopenia, As we all know that anemia and thrombocytopenia are predominant side effects of gemcitabine and nab-paclitaxel. So these side effects were more pronounced in the arm of gemcitabine and nab-paclitaxel. Coming to non-hematological toxicities, it was expected, diarrhea was expected to be more in the nalifrox arm because of irinotecan and 5-FU. It was less common in the gemcitabine and nab-paclitaxel arm. Nausea, vomiting was more in the nalifrox arm, basically because they have a platinum drug with them, and hypokalemia because of the diarrhea was also more common in the nalifrox arm as compared to the gemcitabine nab-paclitaxel arm. Peripheral neuropathy, it was common in both the arms, caused by oxaliplatin in this group and paclitaxel in this group. Now, paresthesia and pyrexia was quite common in the gemcitabine and nab-paclitaxel arm. Next slide. So the study concludes the nalifrox demonstrated statistically significant and clinically meaningful improvements in median overall survival and progression-free survival as compared with the standard of treatment with gemcitabine nab-paclitaxel. 12 months and 18 months difference in the OS and PFS also favored the use of nalifrox over gemcitabine and nab-paclitaxel. OS and PFS benefits were extended along all the cohorts. Subgroup analysis showed it was irrespective of the performance status, presence of liver mets, and age. The safety profile was nalifrox was manageable and consistent with the profile of the treatment components. No new safety components were identified, and this results may lead to the approval of nalifrox as a new reference regime for the first-line treatment of patients with metastatic pancreatic ductal adenocarcinoma. Next.
Yeah, thank you, Dr. Ankur.
And the only limitation of this study is that for our use is that liposomal irinotecan is not available in India. But in my clinical experience, whenever we have used FOLFIRINOX in young patients, they have suffered, they have got a good outcome.
Okay, perfect. So, do you prefer the Gem plus nab-pacli versus the FOLFIRINOX in the metastatic setting? Which regime you prefer?
Sir, majority of the patient of pancreatic cancer comes in advanced condition. So they are provided with they don't have a preserved performance status, and the facts are complicated. They are having a low weight, low albumin levels. So if I found a patient having less than 50 years performance status preserved, I preferred FOLFIRINOX as the first line therapy. Otherwise, I will use gemcitabine and nab-paclitaxel as the first line. Because as per me, older patients tolerate gemcitabine and nab-paclitaxel as a better combination.
Okay, thank you, Dr. Ankur, for this talk. And for next talk, I invite Dr. Kripa Bajaj sir from Hyderabad. He is medical oncologist from Indo-American Cancer Hospital and Research Institute, Hyderabad. And he will conduct a panel discussion on this management of esophageal and gastric cancer with this checkpoint inhibitor. So, ma'am, we will invite all panelists.
Thanks to first of all, I thank Dr. Divesh Goyal and other organizers for giving me this opportunity to discuss regarding upcoming field in the management of gastric cancer. So I invite my panelist, my esteemed panelist, Dr. Surinder Beniwal. Dr. Surinder, are you there?
I think no, ma'am. I think Beniwal sir is not there.
Okay. Dr. Lalit Sharma sir.
I think he is also not there.
Divesh Goyal sir is there, and Dr. Tarachand Gupta.
I think Dr. Tarachand is here.
Yes, I can see Tarachand sir as Dr. Aranya Parik. Dr. Vinod Sharma sir.
Dr. Vinod is also not there.
Okay.
Yes, Dr. Kripa, I am here.
Okay. Okay. We will start. I request.
I think Dr. Ananya Parik is also there.
Yes, sir. Yes. So I request organizers like to share the slides which I shared before in the WhatsApp.
Even ma'am, Dr. Lalit Sharma sir is also joining in 1 minute.
Lalit sir is joining.
Yeah, in a minute.
Sure. So I have Dr. Divesh, Dr. Ananya, Dr. Tarachan, and Dr. Lalit sir is like going to join us soon. So today we are going to discuss regarding role of checkpoint inhibitors in gastric and esophageal malignancies. Next slide, please. So my case treatment is the first case is a 45 years old male who is a known smoker and alcoholic who got evaluated for dysphagia and on evaluation found to have a growth at GE junction. On imaging, he was found to have a localized disease with a few suspicious metastatic lymphadenopathy. Next slide, please. So Dr. Tarachan, so this patient is having radiologically, it is looking like a malignancy. So what investigations do you suggest further for this patient? And will you do any biomarkers in early stages?
Dr. Kripa, just I want to know that you said that there is some metastatic disease suspicious. So where is the location of that metastatic disease?
So G junction and few metastatic nodes, those are localized nodes. It's a regional nodes, not non-regional nodes.
So G junction node, no? So
Yeah.
I think
I'm unable to hear your voice in total, sir.
In this case, no biomarker. Yeah, I'm saying no biomarker is needed.
So
In
you
this
don't want to
case,
do any
because this is the
biomarker.
case, we can go ahead with the curative intent. And for the if the patient has, I think it metastatic workup has already been done, we can consider for the laparotomy if we think for the peritoneal mets if they are there to rule out the metastasis.
Okay.
In G junction tumor, we can consider for that.
Point well taken. Dr. Ananya, it's a localized case.
If non-metastatic on laparotomy, then no biomarkers are needed. We can go with the neoadjuvant treatment followed by surgery and then adjuvant. Yeah.
Okay, sure. Points well taken, Tarachan, sir. So, Dr. Ananya, it's a localized stage, it's an early stage. Do you want to do biopsy and any additional biomarkers on the biopsy?
Yes, ma'am, I would like to go for the biopsy. And as such, at this stage, currently, we only have one predictive marker, that is MSI or deficient MMR, so that we can give the option to the patient of neoadjuvant immunotherapy, sorry.
Okay.
If the patient is MSI high or deficient in MMR.
So you want to do MSI in an early stage as well because you want to offer neoadjuvant immunotherapy.
Yeah. If it is like locally advanced, if the nodes are positive and clinically it is like nearly end-to disease, then definitely I would go for MSI testing.
Absolutely. So Dr. Divesh sir, so what's your take on early stage biomarker testing in esophageal cancers or gastric cancers for that matter? The G junction gastric tumors, type 1, type 2. Dr. Divesh sir? Did Lalit sir join? So no one is there. Dr. Divesh sir is also not there online. Okay. So Divesh sir, are you there? So fine. So my next slide. Next slide, please. So usually I just want to say like usually if we do also the inoperable cancers, we do see 8 to 10% of operable G junctions which are MMR deficient and MSI high. The females have more predisposition than males. As the age passes, we have a more predisposition. Body and distal part of the stomach do have a more incidence than the proximal. This is a G junction, but still I do agree with Ananya. Right now we are also doing the MSI testing because it's moving the, I will discuss the further thing as well. Dr. Tarachan, do you, Ananya said she wants to do MSI testing in the early stage also if it's N2 positive, locally advanced. Do you agree with the fact or with the concept that it's so we can introduce the neoadjuvant immunotherapy in locally advanced G junction? Dr. Tarachan, are you there? Am I audible first of all? Hello?
You are audible.
I don't see, no one is responding. Dr. Tarachan?
Locally advanced. Yeah,
Yes.
Kripa, yeah, I'm here.
Sir, do you want to do, Dr. Ananya just mentioned that N2 disease
Dr.
are locally
Kripa, am I
advanced.
audible to you?
Yes, sir, now you are audible. Sir, just now Dr. Ananya mentioned that there is a possibility and we can offer neoadjuvant immunotherapy for that, for a patient who is a locally advanced G junction. What's your take on it? Like, do you consider that or no? Still locally advanced, like you want to go for a cross protocol, all that sort?
No, for locally advanced, we are going with the cross protocol. That is the usual practice. And I don't think it is FDA approved still now or for the neoadjuvant immunotherapy in esophageal cancer.
Okay.
Yes,
okay.
in a metastatic setting or advanced disease where the curative options we are not considering, we can consider for the immunotherapy.
Dr.
upfront.
Divesh sir, are you there, sir?
Yes, I am here.
Sir, I think you heard my question right. Sir, do you do any biomarker testing? Dr. Ananya mentioned that we can consider option of offering neoadjuvant immunotherapy in this setting. So
I
will you
think-
do? Yes, sir.
I think I am not routinely doing these biomarkers in the early localized settings. So definitely we can do these markers in the metastatic or as well as the locally advanced settings. So I am not doing routinely these marker in localized settings. So I am not in favor of the neoadjuvant, the immunotherapy in this setting right now.
Point well taken. So only one of my panelists is will wish to offer immunotherapy in neoadjuvant.
Like to add that it is like approved. It is a category 2A indication just for adenocarcinoma, and as we can see that the percentage of patients is like really less, and in practical settings we don't usually see such kind of patients who will be like who can afford immunotherapy in neoadjuvant setting, but just for the scientific discussion. So it is a category 2A indication. It is approved now.
So Ananya took U-turn. Now she wants to say that like it's not really usually we do, but it's okay to do if it is really patient is affording. If not affordable, we usually definitely we don't offer immunotherapy. Points well taken from all the three panelists. Next slide. So if ever Ananya, you want to do the perform MSI or MMR testing, which method you want to do it? And what's your opinion regarding tumor mutational burden in this setting?
Ma'am, I usually prefer PCR over IHC. But if it is not, patient is not affordable, I can do the MMR testing with IHC also. And usually TMB we don't do in this setting.
Correct. So next slide. So usually, like even the CAP recommendation says that there is no role of doing NGS for MSI testing. It's either by IHC MMR or MSI PCR. As Dr. Anil rightly said, we can use either of it. So whenever what we routinely practicing is if MMR deficient, like by IHC, we are just going with the treatment like labeling as MMR deficient. But if it is single protein loss or something, some discrepancy is there, we are going forward for the PCR. Routinely, we are not offering PCR because it's not so cost effective, just like IHC. So we are in our center, we are practicing that. And in our center, in neoadjuvant setting, also sometimes we do offer who are affordable patient. The reason why we are doing right now, I'll come to that point later. So TMB I just mentioned, based on TNB, even the metastatic setting or in the neoadjuvant setting, there is no way that we'll offer just because the pembrolizumab trial is there, where for all patients more than 10 mutation burden, we can offer immunotherapy. But in this setting, no, it's only MMR deficient we can offer. TMB high setting, there is no data which is strong to say that we can offer in GE junction or gastric cancers. So next slide. And to the point, like just now Ananya mentioned, so whenever two proteins, like whenever MLH1 is lost, PSMF2 also used to be absent, MSH2 lost, MSH6 will be absent. Either one of PMS2 or MSH6 can be lost. If one MMR protein is lost, definitely MSI confirmation with PCR is really required. Next slide. Dr. Tarachan, GE junction carcinoma, you said you'll do the laparotomy, you'll proceed forward if it is a non-metastatic as a cross protocol setting, right?
Yeah.
If it is gastric carcinoma, will you change the what is your management like?
In adenocarcinoma, especially G junction, or we can say stomach, for G junction, we can either go over the cross protocol or the float by extrapolating the data of the gastric carcinoma, because usually the G junction adenocarcinoma behave like a gastric cancer. So either protocol is okay. And with the gastric cancer, yes, definitely I go with the float regimen.
Okay, you want to go for gastric, you want to go for the float regimen. For G junction, either cross or float, anything you'll offer like as per the description.
Yeah, it's a matter of discussion among the tumor board. What is the preference? Because there is no cross comparison between the cross trial and the float for the G junction.
Correct. There is a new age style which is coming up. Maybe that will answer the question properly. Dr. Divesh Goyal, so what's your take regarding G junction and gastric carcinoma? Like how different you do manage? You do agree with Tarachan sir, or you want to give slot for everyone, or strictly cross for G junction? What's your take?
I think I am convinced with Tarachan. So I will do this, the plot in the gastric carcinoma, and I think the cross protocol for this G junction.
बॉस एग्री होने के अलावा और कोई ऑप्शन भी नहीं है आपके पास मेरे से.
Dr. Ananya?
Ma'am, same as sir said.
Okay. Okay. Points well taken. Plot G junction है तो like either like plot or cross protocol as per the tumor board discussion. Points well taken. Next slide. So the reason why we mentioned before, like regarding MSI high or something in the gastric cancer is, if it is MMR deficient, definitely the whatever adjuvant or neoadjuvant we are introducing, it's not going to benefit much here. MMR deficient is a prognostic and predictive and operable GEJ. MRD has an excellent prognosis with surgery alone and are resistant to 5FU platinum. We do know oxyl platinum resistant, but like definitely if you MR deficient, we have double discussed whenever patient is having a strong family history. If we do that, if it is a deficient, advantage of offering it is very minimal. The trials are coming up for the adjuvant immunotherapy as well as neoadjuvant immunotherapy. I do mention a brief stint on it. So MR deficient, it's a very predictive. It's a predictive whether to we offer chemotherapy or not, just whether to give a neoadjuvant setting the benefit of all this stuff, or to take up for operation alone without any neoadjuvant or adjuvant treatment. So this will consolidate soon, because basket trial is happening for the stomach cancer as well as G junction cancer to omit chemotherapy totally and to introduce only immunotherapy for this setting. So I mentioned before, it's 8 to 10% of gastric and G junction cancers will have a deficient MMR. Next slide. And also the neo-Nipigna trial, what Dr. Ananya rightly mentioned, this is a very promising trial where the I'm not going to checkmate 649. Neo-Nipigna trial, which was present in ASCO 2022, was the most talked about for the gastrointestinal malignancies. In this one, neoadjuvant introduction of Nivo plus ipilimumab, total 1 year immunotherapy, 3 months before and 9 months later surgery. So there is an excellent CRs got noted. The PCRs are as high as 60% with the outcome as good as the overall survival hasn't reached. So the responses were quite good. So maybe in future, all of us will do the MSI testing. The category 2A may go up to category 1, because I mentioned before 10% of the cases will have a probability of having MSI deficiency. So that's why there is no point of offering RT or chemotherapy, neoadjuvant or adjuvant setting for such patients. Better to introduce only immunotherapy. This is going to be the future, but I'm just want to brief it for the interest of the discussion. Next slide. So next slide. So Dr. Tarachan, I'm just to the pathological purpose, I'm asking, if ever you want to do the PD-L1 testing, which antibody you choose?
SP263.
SP263. Okay. Dr. Ananya?
I think for Nivo 288, that is the antibody for Nivo, right? If we are planning for nivolumab, or mostly SP263 only the labs are using.
Okay.
The problem is, Kripa, that if we go for the separate, for the different, for the Nivo different, Pambro different tumor, it will be very difficult to do PDL1 for every time. Correct. I think single platform SP263 is acceptable, in my opinion.
Points very well taken, sir. Dr. Divesh Goyal, what's your take? Like, which antibody do you use?
Yes, SP263. I think I'm convinced with Tarachan.
Next slide. So I too got convinced, like we also use SP263. As Dr. Anna mentioned, though IHC 288 is for nivolumab for sure. But SP263, there is a very good concordance is there. It's a blanket antibody all of us are using right now, be it Pembro, Nivo, Durva. Even the lung, there is a blueprint says that there is a very good concordance with the SP 142 for Atizo as well. Next slide. Next, so no, previous slide. So already Dr. Tarachand mentioned in the beginning itself, this patient was taken up for CTRT and she underwent surgery. There is a residual disease. What options you discussed with them? For all histologies, the same approach.
I will fill in the blanks with nivolumab if they are affordable.
For all histologies, be it squamous or
Yeah, basically it is
histologies.
more in the favor for the squamous cell, and not in adeno if we are giving peri-operative. But if we are going with cross trial, I think nothing is harm in nivolumab. It may be extrapolation from squamous because if we are going with cross trial, because that was the cross trial which was taken into consideration in that trial of nivolumab post residual disease. That is the only thing.
Dr. Divesh?
I think same. I think that we will offer the nivolumab for across all histology.
So you'll not say like this histology, just to Tarachan mentioned, like this histology, you will do this, like that histology you'll not offer. Is there any difference?
No, I think I will offer across all histology.
Okay, absolutely. Well, Dr. Ananya?
Same, ma'am. Both adeno and squamous.
Okay, sure. Next slide. So the discussion what we just now kept is like regarding the Checkmate 577 trial, whether to offer the patient. In this trial, both adeno and squamous got involved. The patients who are having a post-CRT surgical resection with residual pathological disease got randomized to Nivo versus placebo up to 1 year. Next slide. The response rate were like very good. If you see the squamous histologist got a benefit most compared to adeno histology, the hazard ratio is 0.61 for squamous. It's like 0.75, though it's like suggesting, but it's not giving a great benefit like squamous. For squamous, it is 11 versus 29.7, almost like more than doubling. For adeno, like 11.1 versus 19.7, though hazard ratio is 0.7, it's not so significant. Next slide. So there is a magnet benefit with offering nivolumab, especially squamous. So my next slide, like what we do see most commonly is a metastatic setting. So my patient is 60 years old male who got evaluated with dysphagia and abdominal pain. He got evaluated and found to have a metastatic adenocarcinoma of the stomach. So Dr. Tarachan, what biomarker testing you want to perform? You just mentioned before you want to do some biomarkers in metastatic, but not in the neoadjuvant setting.
Yeah, in this setting, I will go with the HER2, ISC for HER2 and PDL1.
That's it.
Yes.
Dr. Divesh?
HER2, MSI and PDL1.
Okay. Dr. Ananya, you want to add on something?
HER2, MSI and PDL1.
Yeah, you want TMB, Dr. Kripa?
No, I just mentioned TMB doesn't make any sense in stomach cancer. Next slide. So I agree with the other all the panelists that HER2, MMRD, as well as PDL1 we do test. But the first line setting, definitely all these things we have, all these three things we have to see. Upcoming FGFR2 and all, like right now, no one is doing most of the thing except in the NGS, like where they want to really explore everything. But usually these three are the standard across the country. Next slide. So, Dr. Tarachan, why you want to do this? Where you want to introduce immunotherapy in the management of the stomach cancer? So, tell me, like where first line setting, second line setting, what factors you do see?
If the patient, according to the trials or the data, we can offer in first line is also if the patient is HER2 positive also with the immunotherapy, but with the CPS score more than 5 or more than that. But my personal choice is the patient should be driver mutation negative to offer an immunotherapy with a CPS score more than 5 in first line along with the chemotherapy.
Okay. Dr. Divesh, go ahead.
I think same. MSI.
Sir, your
This is
voice is
also-
not audible, sir. Your voice is not clear, sir.
Okay. So just as Tarachan say that MSI and CPS, if there is no targetable actionable mutation, then upfrontly offer this immunotherapy along with this chemotherapy.
Okay. Dr. Ananya?
Yes, ma'am. Patients should be offered immunotherapy in the first line along with chemotherapy if with the CPS score more than 5 or MSI deficient, MSI high.
Correct. I agree with all the panelists. I'll just discuss regarding like why we want to introduce like with a brief mention. Next slide. So this is Checkmate 649 trial, which all of us are talking just now. So this trial has proven the introduction of nivolumab along with the chemotherapy combination is a proven to be benefit if CPS is more than 5. There is a good benefit in OS as well as PFS. Checkmate 649 included patients who are adenocarcinoma, CPS more than 5. Next slide. In this one, there is an excellent outcome. All randomized versus CPS more than 5. There is a good outcome got noted in the patients, and there is no benefit for PD-L1 less than 5. Next slide. So MSI, just now Dr. Ananya mentioned, yes, not just CPS, MSI high people also have a very good outcome. In Nivo plus EP arm, like the Checkmate 649, Nivo plus EP hasn't shown OS benefit for patient who is having CPS more than 5. But Nivo plus EP has shown a benefit in patients who are MSI high. The overall survival hasn't reached. There is a good response rate. There is a good overall survival in patients who are MSI high with Nivo plus EP versus chemo. But Nivo plus chemo versus chemo, it was like not mentioned, but Nivo plus EP, there is a significant benefit is there. Nivo plus EP versus Nivo plus chemo, there is a good outcome for Nivo EP. That's why it was more mentioned regarding the combination of IO, obviously for a MSI high patients. Next slide. So this is the one Checkmate 6-4 and Orient, like Sintilimab, like none of us are using, but there's a very good response rates and outcome got noted with the CPS more than 5 patients. Next slide. And just now I mentioned 648 is for the squamous cell carcinoma. In this one, PD-L1 more than 1% is like fine to offer chemo plus IO. But for that one, CPS more than 5, for this PD-L1 more than 1%. Next slide. This is the one like in conclusion, EMA usually what do we follow in India? Like we do follow the European protocol. For the first line, beta adenocarcinoma, squamous cell carcinoma, CPS more than 10, blanket, we can offer pembrolizumab as per the keynote 590. But squamous in the first line, more than TPS, there's a tumor proportion score more than 1. For adenocarcinoma, more than 5. So this is based on the Checkmate 649, 648. And second line, all of us know, all of us are using it like, irrespective of it, like we are second line, we are offering nivolumab as per the attraction. Dan Singlation, Pembro, Nuvo is having a better data for the second line, though it's a minimal, but still all of us are offering. Second line, gastric adenocarcinoma, G junction, MSI high more than 10, like yes, we are offering pembrolizumab as a blanket, but there's not much benefit is there. So the tumor mutation burden high, there is no significant benefit with adding pembrolizumab in gastric cancers. But still, all of us, when nothing is working, we do just make something work just like that, but nothing is there. That's it. So for nivolumab in the adjuvant setting, there is no biomarker needed. We can add only histology matter, but doesn't make any sense regarding CPS or TPS. But in the combination of IO plus chemo in the first line metastatic setting, yes, CPS and TPS does matter to us. And second line, it's fine to offer in the nivolumab without any biomarker. But for the pembrolizumab, CPS has to be like more than 10, but still we are not offering keenly. The nivolumab we are all of us offering. So tumor mutation burden high doesn't make any sense in the gastric cancer. This is in conclusion the final slide. So I think it's good to stop and discuss regarding any case dignities. Dr. Divesh Goyal, thanks for giving me this opportunity.
Yeah, thank you, ma'am, for very nice moderation. And I think thank you, Dr. Tarachan and Dr. Ananya and Dr. Lalit for this discussion. Any question from Tarachan, your side?
Thank you, boss, for the opportunity. You have answered my all the queries very well, and Kripa has moderated very well. So nice. It was a nice session.
I think Dr. Ananya is the newer in our city in Jaipur. I think still we have not met. So I think there is very nice discussion. Any view, any comments, Dr. Ananya?
Thank you so much, sir, for giving me this opportunity. And I think, sir, you're also from GCRI. Like, I just know you that you're from I am from GCRIs, and there are many people here, but I would like to definitely meet all of you.
Yeah. Definitely, we will meet and we will connect. And I think that Tarachand will organize.
बस ये GCRI वाला फंडा नहीं चलेगा, बस मैं पहले बता देता हूँ.
I think that Tarachand is in young and dynamic medical oncologist from our in the Jaipur.
I would like to meet all
बस ये
of you.
GCRI वाली unity नहीं चलेगी, ये अलग से
No. I am just saying that Dr. Tarachand is the very young and dynamic oncologist in our city Jaipur.
नहीं बस young कहने के लिए thank you बस, मतलब मजा आ गया मतलब, पर GCRI वाली unity नहीं चलेगी.
So thank you, Dr. Kripa ma'am. So
Thank you, sir. Thank you, sir.
Yeah.
Thank you for the opportunity, sir.
हाँ, चलेगा, okay. Thank you.
So, concluding this session, and following this, we will conclude the 2-day talk of recent updates in this that on cancer. So yesterday we discussed about the as well as the lung cancer, and today we discussed about this GI and GU cancers. So definitely thanks to all faculties as well as all faculties, moderation by the Kripa ma'am and all panelists for participating in this event. And thanks to all the delegates to attend these meetings, and thanks for all pharma company for their to be part of this academic feast, all scientific partners. And thank you, Dr. Tarun, and thank you your team, Vishal, as well as other members from the backside. Thank you all.